So formally, I'll introduce myself. My name is Heidi Probst. I'm Professor of Radiotherapy and Oncology here at Sheffield Hallam. I'm also the Director of the Health Research Institute, and I'm co-facilitating the Healthy Futures lecture series with my colleague, Professor John Wheat, who is the Associate Dean for Research and Innovation for the College of Health and Wellbeing and Life Sciences. The College of Health and Wellbeing and Life Sciences is reworking and enhancing its courses and curricula to ensure that our graduates are given the applied skills and knowledge and experience to be successful in health-related employment in the future. And at the same time, the university is implementing an exciting new research and innovation plan led by Professor Rory Duncan. And the ambitions of that plan are to grow our research and innovation offering here at Sheffield Hallam. And in order to grow that research and innovation offer, we need to ensure that our research aligns with the research priorities of the major research funders, but also the major challenges that are faced by communities locally, regionally, nationally, or in a global context. We know that there are multiple factors that influence health and well-being. The Healthy Futures lecture series aims to provoke and inspire colleagues both within and outside of the university on a wide range of topics relating to health in its very broadest sense. We want to challenge assumptions of health. We want to push the boundaries and spark new ideas and innovation and connections across disciplines. That's the purpose of these sessions. So today's lecture is going to be delivered by Dr. David Rogerson, who prefers to be called Dave, so I'm going to refer to him as Dave from this point onwards. Now, Dave works in the Academy of Sport and Physical Activity as a principal lecturer. He specialises in sports and exercise science, particularly strength and conditioning and sports nutrition. So Dave has held a number of roles during his time at Hallam. He's been the subject group leader for the Sports Science and Physical Activity subject group. He has led the BSc Honours Sports Coaching, the BS Honours Sports Science for Performance Coaching, and the MSc in Applied Sport and Exercise Science. Dave has also developed with colleagues and industry partners the MSc in Strength and Conditioning Coaching, and this course adopts a practice-based learning and was developed directly with industry to meet the needs of applied practice specifically, and it's about working with people rather than just theory, making it one of the first of its kind. So Dave also supervises PhD students, and at the moment some of those are exploring strength training in performance, specifically the impact of too much training and health-related contexts, as well as lifestyle interventions for the treatment of hypertension in people of African descent. David has published over 30 peer-reviewed journal articles, has appeared in over 20 media pieces across the globe, including Channel 4 and the BBC. He's currently a topic editor for Frontiers in Physiology and the senior section editor for Journal of Sport and Exercise Science. So Dave has provided strength and conditioning support and exercise and nutritional support within the professional and elite sport, including athletes that competed at the 2012 Olympic Games and the 2014 Commonwealth Games, but also via the Talented Athlete Scholarship Scheme to young athletes, as well as members of the general public. Dave has worked with sports as diverse as volleyball, ice hockey and fencing, rugby, including rugby union and rugby league, and weightlifting. He's acted in a consultant role to English Institute of Sport, specifically on the topic of plant-based nutrition, and to the National Health Service, specifically on harm reduction, performance-enhancing drugs within the non-opiate service for Sheffield Treatment and Recovery Team. So it gives me great pleasure to introduce Dave to you today, who's going to present on clinical strength and conditioning, high performance knowledge for health, well-being and longevity. And I'm going to hand over to Dave now.
Oh, thanks very much, Heidi. Thank you very much, everybody else, for taking the time out of your Thursday afternoon to come listen to me talk. I've got a series of slides today, and while I've posed this really as a lecture, it's also slightly interactive as well. So be careful, watch your mouse. I might actually get you to try to participate a little bit as well as sit here and take some information in. Okay, so I'm going to get started, and really what I'd like to start with today is really what I'd like to achieve with the time that I have people present. And the first thing that I'd like to do today is kind of examine a couple of things, and really the first thing that we are going to examine is the Chief Medical Officer's physical activity recommendations. And kind of specifically with that, we're going to have a look at the strength training recommendations. Secondly to that, what I'd like for us to do is actually have a bit of a discussion, and really the discussion we're going to look at is clinical exercise, what I've called clinical exercise. And I'm going to let you on a little secret, and I've kind of had a little bit of a white lie, and we're going to discuss more than just clinical exercise, and we're going to discuss exercise in a community and perhaps even a social prescribing context as well. But specifically what we're going to look at is the role of strength training and strength and conditioning science kind of within that space. And the final thing really that I'd like to do is kind of highlight the potential, what I see in this university right now. And I kind of feel that this university is in an ideal position really to be at the forefront of knowledge and education in this particular field, and very much be the leader in the knowledge and education provision in strength for health-related contexts. How am I going to achieve that? Well, I've got 3 goals. The first is I want to provoke a little bit, not unusual for me if anybody does know me. And specifically what I'd like to do is provoke a little bit of thought and inspire some conversation and debate. Some of the things that I'm going to discuss have actually online created a little bit of controversy, and really what I'm trying to do today is not really to question or prod the bear with respect to any particular health-related discipline, but I'm really going to sort of challenge and provoke a little bit of thought, I think, about the role of some health-related disciplines. What I'd also like to do is present, and I'm going to present to you today 3 problems that I think provide an ideal area of opportunity for us as an institution. And specifically what I'm going to do is going to highlight some existing practices in the field of exercise in health-related contexts, but also to illuminate and highlight some real fantastic new possibilities that I also see present as well. And the final thing is I want to promote something, and what I'd like to really promote is something that's very close to my heart, as probably might have become clear from Heidi's introduction. And that is that strength and conditioning science and strength and conditioning practice. And I'm going to give you a couple of anecdotes to kind of really highlight the amazing benefits that can be kind of gleaned from engaging with this type of activity. And I'm going to promote strength and conditioning really as a potential solution to some of the problems that I'm going to talk about and present today. So that kind of leads me nicely on to the very first thing that I wanted to discuss. And I suspect that this is of no surprise to multiple people in the room right now. And this is the Chief Medical Officers, the UK Chief Medical Officers physical activity guidelines for the UK population. And what I'd like us to focus on very specifically is that kind of red, kind of brown sort of circle area in the middle, which is about building strength. And the recommendations are quite explicit that for adults, age of 19 to 64, and even 64 and older adult plus, is that we should be building strength on at least 2 days per week. I think that's quite an interesting recommendation, really, and it's music to my ears, really, as a practitioner in this area. And I think it's perhaps potentially something that needs to be explored in a little bit more detail. What's really interesting is these guidelines were updated in 2019. They were originally first presented to the UK audience in 2011. If we look at the 2019 Chief Medical Officer's document, what it highlights and discusses within there specifically is how we being, I guess, health-related organisations and society, have perhaps potentially undervalued the role of strength training within physical activity and health and well-being related contexts. Perhaps more needs to be done with to kind of promote and engage people with this kind of exercise. And that is something that I want to focus on and discuss a little bit later on. Something else that I thought was really interesting as I read through the document, and not like I've read through it in any detail, but on page 31 of the document, what it does highlight as well very specifically is how to actually achieve that. And it gives recommendations to exercise the muscles of the upper and lower body to the point of what we call volitional fatigue or exhaustion. And that is the concept that we can't move them any more than they are right now. It's a concept in strength and conditioning called concentric muscular failure. But hopefully by the end of the session today, we can kind of see that might not necessarily be the case. We might not necessarily need to do it in that particular way, and that there's nuance and context and detail and application, individual application really with strength training as well. Thing to take away from this slide, please, is that the strength training appears to be something that's considered to be very important for our health, and certainly is appearing very much so on health-related guidelines. But there might be a little bit more work to really sort of promote that and to provide very specific recommendations. All right, so that kind of leads me on to my first thing that I'd like to do. And actually what I'd like to do is to get you to do something, all right? So what I'd like to do is have a quick think. I want you to think about any particular health-related benefits of engaging with strength training that you can think of. Maybe pop one or two in the chat right now if you can kind of do that. Just, maybe think about, well, what is it that strength training actually does to us from a health related context, regardless of who you are and regardless of kind of what you do. Hopefully one or two will start to appear in the chat, and then once they do, I'll sort of roll through a couple of things that are on the slide. Okay, so I'm slightly conscious as well of time, and I've got lots to talk about. So what I'm going to do is I'm just going to show you. If you've written any of these down, now look, I'm fully aware as well at the same time that these are technical concepts, and there are going to be some technical language and terminology that does come within what I'm going to talk about today. But I'm going to talk about it from an illustrative context really, rather than an explanatory context. If you've written anything like this down or anything broadly related to any of the benefits that I've just highlighted, give yourself a gold star or a little gold ribbon. You've done well. What I think is also really, really important and really interesting is two things that have emerged from the literature in recent times. First, and the second, examples of literature right here point to the benefits of lifelong participation with resistance training and the potential benefits that actually engaging with this activity earlier on in life, that it actually has and carries later on down the line, once we get a little bit older. And what the evidence is starting to point towards is lifelong benefits of engaging with strength training and resistance training in terms of our function, our ability to move, experience space, and our ability to lift, carry, stand up, sit down, locomote, walk around. But also I guess the integrity of our skeletal system, the integrity of our muscular system, its resistance to injury, and its ability to kind of withstand the stresses and strains of everyday life. That carries on throughout life if we start to engage with this as an activity. That's really, really important. And that is incredibly important in light with some of the things that we're going to discuss as we go through the slides, which I hope become quite clear. So that leads me really, really nicely, actually, and to the context that I'm going to present and discuss today, right? What I'd like to discuss today, and really how I wanted to contextualize this presentation specifically, is around an individual who has made an incredible, I guess, mark really on my career to date. And when I was a student many, many years ago, hold your breath, it was quite a long time ago now, what I did alongside studying was I also worked in gyms. So I worked as a fitness instructor at first, later on as a personal trainer, and I eventually navigated into strength and conditioning practice, into further education, and then I eventually came to this university in 2006, 2007. This lady that I'm going to talk about was the very first individual I ever worked with in a gym-related context, and it was an older lady. And it was an older lady who kind of characterizes every stereotype that you can think of with respect to someone who's elderly. And I'm going to present to you and show you some pictures, not of this lady, but of some stigmatizing images that I think we need to get past. Well, unfortunately, this lady really did represent those stigmatizing images of somebody being quite stooped over, somebody using a walking stick. And unfortunately, this lady also had experienced, before she came to me, a car accident and had an accident. And as a result of that, she lost some of her peripheral vision and she used walking sticks. And so she came to me wanting to exercise and wanted to feel a little bit better. She wanted to lose a bit of weight. And she was someone that couldn't really move very well. She was experiencing a little bit of pain. And I realized very quickly once she sort of came into the gym environment, actually that was a massive ask for her to do. It was an incredible feat of, courage of stepping into that gym as an older individual who experienced health-related conditions, who had these problems. I put her on a very simple basic exercise program. I worked with her one-to-one for a period of time. And over the course of around about 6 months, the transformation that this lady went through was absolutely unbelievable. I mean, as a university, we like to sort of pride ourselves and talk about transforming lives. And if anybody could characterize and typify what transforming lives was about, it was this lady. She came to me with walking sticks. She came to me with someone that couldn't really see kind of beyond here, and someone who was very sort of enclosed, and someone who really didn't want to engage with the outer world. After a 6-month period, she didn't use walking sticks anymore. She did her hair differently. She wore different clothes. She didn't need me to work with her in the gym to go and do different things. She'd regained more than just, a physicality. She regained confidence, and she regained some aspects of her independence. And the way that she thanked me before I left that particular environment has stayed with me to this day. The fact that, when I was 18, 19 years old working with this lady, I'm much older than that right now. I still talk about her in my lectures, and I'm talking about you to this day. That is something that characterizes and really represents what I think is the incredible power and potential of this mode of exercise to make a difference to a human being. The context of what I want to present to you today is an aging society. So I'm going to present you some facts and some figures. It might be of no surprise to anybody that's in this room right now. As a population, the UK is aging. Currently, 19% of the population is 65 years or older. By around about 2050, the estimates are that roughly a quarter of the population will be over 65. Unfortunately, as we age, we become a little bit more inactive, and we have this situation where if we combine physical inactivity as well as some of the things that kind of happen to us organically as a result of aging, we start to accumulate conditions, and we start to accumulate things called non-communicable diseases and a variety of other potential diseases and conditions as well. Unfortunately, aging, long-term conditions, diseases such as these are associated with increasing healthcare costs. And specifically within the UK, the chronic diseases and chronic conditions such as these are the largest financial healthcare burden in the UK. As I was kind of researching this and kind of looking into this detail, it actually surprised me to find out that healthcare expenditure is currently increasing beyond the rate of inflation. It's a perfect storm. We've got an aging population that are perhaps increasing or not necessarily as active as we might want them to be. We're accumulating conditions. It's creating this downstream effects in terms of healthcare burden and healthcare costs that are rising beyond really what we would like them to do and what they potentially should be doing. That's a real issue. That's a perfect storm. But what we know from the research and what we know from the anecdote that I just provided a moment ago, and what we know from the things that I asked you to contribute to the chat, is that exercise, physical activity, moving our bodies can help prevent and manage conditions. That is, again, probably of no surprise to anybody in this room right now, but I think it's important. And I think really it's of no surprise then that if we know this and it's so clear to us, that when we start to look at some of the strategy documents of things of organisations like Sport England, the Sport England strategy is very, very clear and explicit about the promotion of physical activity and getting people moving. The National Health Service's long-term plan is around, let's move and transition away from being a reactive model that treats issues once they start to manifest, to actually getting people engaging with them in physical activity and exercise to prevent things and reduce the impact of things before they happen. It's of no surprise that with these benefits, that this is how various different strategies of major organizations are starting to appear. So aging and function, what I think is really important, again, I'm going to go into a little bit of detail and some technicalities, and I want to do this from an illustrative perspective to kind of highlight, I think, the role and benefit of exercise and this activity, what it can provide. So here's a picture, and there's a picture that I took from some literature. I'll have the reference in a moment or two. And I said earlier, didn't I, about a stigmatizing image or a stereotypical image that we might have of people once they get a little bit older. And I was a little bit saddened and surprised to see that was in this piece of research. But I guess that's what it is. What this represents is, I guess, a multi-level, a multifaceted, complex range of factors that leads to our loss of function and our loss of our ability to utilize and move our bodies effectively and efficiently as we get older. So due to environmental, lifestyle-related factors, biological factors associated with aging, psychosocial factors, what we start to see is this mixture creates and couples with just getting older, downstream effects on our nervous system, on our muscular system, on our skeletal system, that leads to a loss of function. It leads to a reduction in flexibility. It leads to a reduction in the ability to produce force. It leads to all sorts of range of different issues around coordination. And if we wanted to unpick those in a little bit of detail, that's really what this stigmatizing image from another piece of research also represents as well. And what this kind of represents quite nicely is, I guess, the effects of something called sarcopenia. And another condition, sarcopenia, is the age-related loss of muscle mass. There's another condition as well called dynapenia as well, which is an age-related loss of muscular function and muscular strength. What happens when we get a little bit older are a variety of different, I guess, a cascade of events that happens within our muscle tissue that kind of leads to these things. And I'm going to keep it simple. What happens as we get a little bit older and we start to age, and we might not necessarily use our bodies as much as we might do when we're younger, we start to see a decline and a reduction in our ability to generate force from our muscles. So our muscles become a little bit weaker. As well, once we get a little bit older as well, if we're not particularly active in the way that we should be, we also start to physically lose muscle mass. So that the volume, the size, and the amount of muscle fibers that we have actually starts to decrease as well. We actually lose muscle tissue as we get older. That aging process, that process itself, what we also see is a change in the characteristics of the muscle that we have. So not only do we lose their function and we lose their volume, the amount, but they also lose their characteristics, and they transition from being something that can produce force and produce and react to force quickly to no longer having that ability. That's really important. It's really important in a health and an aging related context, because when we hear about people falling over, and when we hear about elderly relatives, we might even experience this in our families, have fallen over and damaged or broken a bone, the ability to react to a trip or a fall is contingent on our ability to react in a way that's quick and explosive. If our muscle fibers are losing that characteristic to be forceful and explosive, where we're increasing our susceptibility to fall. One of the major risk factors that people look for with aging is, in terms of a loss of function, is a reduction in grip strength, is a reduction in the ability to move our lower body in a way that is explosive. If we can start to ameliorate and accommodate some of these potential issues, then we could potentially address and I guess work towards preventing or reducing the impact of things like trips, falls, and a variety of other things. One also thing I just wanted to sort of highlight very quickly on this slide is a reduction in locomotion when people get older. I look and think about some of my elderly relatives and see how they've kind of slowed down a little bit as they get older. They kind of shuffle a little bit. I'm thinking of one person in mind. And really that is this in action. That is that loss of these type 2 high threshold motor units, what we call them, you know, these fast twitch muscle fibers, what we call them. It's a really, really sad thing to happen. But as we're going to reveal and go through some of the slides, it doesn't have to happen. Okay. So with that in mind, hopefully I've not depressed people too much. Second task for you. What are the benefits of strength training in older populations specifically? If you can think of anything you might want to just pop into the chat, I'm going to do a similar kind of thing as we did a moment ago. I want you to think about it, maybe reflect, write one or two things down, but I'm going to give you the answers anyway. I'll give you a couple of seconds to start to appear. Okay, some things are starting to appear. Fantastic. All right, I'm going to move on. It perhaps comes as no surprise to anybody, bearing in mind the conversations that we've just had, that these things, these health factors on the left-hand side of the screen are associated with getting a little bit older. A reduction in strength, a reduction in muscle mass, a reduction in VO2 max, which is, I guess, a mechanism behind which we can assess someone's aerobic function. Their function, their ability to move and navigate space, their ability to pick things up and to carry things around, we call them activities of daily living. Cardiovascular risk, cancer risk, and inflammation. These things are all affected by aging, but lo and behold, there's an evidence base behind resistance training how it could potentially either reduce the impact, reverse some of these things, and potentially improve some of them as well. Wow, that is amazing. We talk about exercise as medicine. If this is not evidence of exercise as medicine, I really don't know what is. So strength training has all of these incredible benefits associated with it. We need to get people active. We need to get people moving more. We need to do what the chief medical officer is suggesting and getting people to exercise 2 times a week using some sort of resistance-based activity. What they also talk about with an older population is to get them to do some balance-related activity to prevent falls so that people don't actually put themselves in a position to need to react. So resistance training participation, how many people are doing it? Unfortunately, and perhaps again, not really so much of a surprise, population level engagement is actually very, very low across the globe. I'm afraid I don't have the data very specifically for the UK, but we do know that broadly speaking, population level engagement with this type of exercise isn't really where we'd like it to be. Why is that the case? Well, there's large barriers to this. I wouldn't be surprised if we delve into the evidence a little bit more so. There's a whole range of different inequalities that are associated with it, a whole host of social determinants. I can guarantee there are a large range of social determinants, but there's an incredible amount of barriers to engage in this activity. Some of these barriers are going to exist on a systemic level, on a societal level, and perhaps some of those barriers might also exist on an individual level. Again, around some of these issues to do with stigmatizing, some of these issues around with stereotyping, some of these issues around really, is this something that I can see myself doing? Interestingly enough, stigma, intimidation, perceived to be injurious, perceived to be something, if I do it, I'm going to hurt my back or I'm going to pull a muscle, seems to be some of the barriers that have been articulated for older individuals. There's work to be done to educate people about the safety of this exercise. As well, there's a lack of guidelines. There's a lack of detail and information and messaging that is aimed specifically at this older population. This is the first problem that I wanted to talk about with this lecture today, was the first problem. I said 3 problems. The first problem is an issue of participation. We need to get people doing that stuff. We need to get people moving more. Now, I am aware of the National Centre for Sport and Exercise Medicine. I am aware of the Move More. I am aware of the incredible work that is already going on in this space within this institution and its associated organisations as well. But if we reflect back to that Chief Medical Officer's guidelines and what they discussed, and one of the things that they do suggest in there is that perhaps we have underemphasised the role of strength training, the role of resistance training. Well, perhaps we need to do a little bit more. The other thing that I want to sort of touch on and highlight is the topic of this is clinical exercise and clinical strength and conditioning. Who is it that's out in the community or out in the clinic or in a hospital environment, not necessarily just a gym environment, that's providing these services, providing people with the knowledge and providing people with opportunities to engage in activity? It's incredibly consistent. So when I was researching and looking for this and looking through this lecture, I sort of navigated a range of different literature and I wanted to really find out in detail about this. And I had the opportunity to speak to some colleagues in the Academy of Sport who really are experts in this space. And it's really, really surprised me to find that there's incredible disparity and inconsistency in clinical exercise across the UK. Roles can vary on the basis of region. Roles can vary on the basis of what clinical context we're talking about here. Cardiac rehabilitation is considered to be, I guess, a model of good practice, and I suspect it probably is. But the models that are taken with respect to exercise and cardiac rehabilitation and the education, the training, the competency requirements might not necessarily be transposed to other discipline areas or to other contexts as well, which is really, really interesting. Again, I'm not an expert in this particular area, but I found that really, really interesting. What's also, I picked up on it in the literature as well, is where there's dual practitioners. And actually, you know, we spoke about healthcare burden and healthcare costs as being an issue. And potentially this could be perceived as actually being quite cost effective and efficient. We might have situations or contexts where allied health professionals are also providing, you know, clinical exercise in regard to strength resistance training. Sometimes potentially, however, without CPD and training to kind of underpin that, which is not necessarily a worry, but I guess it kind of highlights that disparity we spoke about a moment ago. What's interesting is that some of the countries, now I'm not necessarily saying that these are a model of best practice, but it's an interesting concept for us to pause and think about for a moment. Australia, US, and Canada seem to have specialist accredited clinical exercise physiologists and exercise routes. I also came across an article as well that discussed Australia specifically, and it suggested that there's around about an $11,000 to $12,000 annual well-being gain associated with the presence of these professional practitioners, i.e. there's healthcare savings associated with actually having people in practice who are providing services in terms of the overall cost on the health services in these other countries. We have exercise referral schemes. So things don't just also happen within a clinical context. They do happen sometimes without in communities. But again, the evidence has also critiqued, you know, the role of exercise referral schemes, specifically in terms of how they're designed, delivered, maybe overly focusing on exercise, not necessarily focusing on physical activity. Some of the critiques have also been around the length of these kind of services, being quite shorter in length, not considering longer term kind of trajectories. It's perhaps not for me to critique kind of the roles of these, but I think this represents, more broadly speaking, the second problem that I wanted to highlight. And the second problem that I wanted to highlight is if this is the situation in the country or in the UK, where we have disparate services, disparate practices, sometimes people not providing services without necessary knowledge and training, then there needs to be something done to standardize practice, to standardize education, to perhaps look at CPD that's available for people that are practicing, and perhaps to provide competency requirements and to provide some way of creating consistency. Now, some of you might have seen this. And this was one of the things that became a motivator really for me to do this lecture today. And it came to me as no surprise because I've had conversations when we developed our master's degree in strength and conditioning a number of years ago, that one of the things that was spoken about when we were developing that master's degree program was that at some point we're kind of expecting and might suspect that some of this knowledge, some of these skills might transfer over into the health sphere. And earlier on in the year, I came across this. And this is Leeds Teaching Hospital, who advertised for a strength and conditioning practitioner. And it's a role that kind of exists within the orthopedic team. It's an outpatient orthopedic clinic. They manage their own caseload. They have assessment and management of patients. They also do work in the community as well, face-to-face as well as online work. And it's a joint working model with the physio team, okay? Physio team might triage, and then they might then refer later on to the strength and conditioning practitioner. It might provide some different type of exercise or work with people in a small group, or even, I guess, an individual kind of level. They work in early phase management, but also chronic conditions as well. I was very fortunate to be able to be connected to the person that developed this role and advertised for this role. Had a conversation with that individual as well. The feedback was that this has been of fantastic benefit to that particular clinic, which was music to my ears. It doesn't surprise me that this has happened, and I'm not necessarily saying that this is how it needs to happen, but I'm not surprised that we're starting to see the transferability of this knowledge over into different contexts. So what is strength and conditioning? Well, that might be a question you're asking yourself right now if you're not necessarily aware of actually what is this and what is it all about. It's the physical and physiological development. It's about developing the physical capacities of movement, of lifting things up, of putting things down, of walking, of running, of jumping, of carrying, of pushing. It's also about injury reduction, injury management. It's also about physiological development in terms of adaptations to exercise. And that can be on a metabolic level, but also a physical level as well. It's applied exercise science. For strength and conditioning is applied practice of sport and exercise science, sport and exercise physiology. They're specialists. They're specialists in assessing and monitoring function. They're specialists in the prescription of exercise training for the achievement of some sort of outcome, some sort of physical related outcome. They're also experts in assessing and monitoring and prescribing exercise, as I mentioned. I've got a little video. Hopefully this video will play. I wanted to play this video again to highlight the fantastic work that we do. And again, I'm aware that I'm patting myself on the back a little bit with this, but I had the pleasure to work with Jordan, who's in this video right now. Some of you might have seen this before. And this kind of just highlights, I guess, some of the fantastic work that we already do in a performance context, not health, in this area. Hopefully.
I'm one of the strength and conditioning coaches at Sheffield University, and I also study sport and exercise science. As a graduate,
you know what I'll do is I'll just talk around that rather than play the video if people can't hear it. So what I wanted to demonstrate really with this video was Jordan was one of our master's degree students. He came on our undergraduate program. He came onto our postgraduate program. He went through an internship program that we have within the university. And the internship program provided him with opportunities, experiences to develop the skill set. We then provided him with an opportunity to travel abroad to the US to further develop his knowledge and skills. What I want you to be able to get away from this particular slide is that we're already doing fantastic things in this space. We've already got experts in the provision and the knowledge and the teaching and the education of strength training and strength and conditioning. We've got students coming through a well-established program with a rich heritage. We're doing fantastic work in this area. So I'm going to move on because I don't want to sort of spend too much time on that one particular slide. And what I wanted to highlight with that very specifically is if we are doing some of these things already, well, perhaps there's some opportunities I've highlighted previously with respect to some of the issues with the industry, then perhaps we've got some of the expertise to start to address some of those issues. Maybe what we can do is start to look at some of the education, training and CPD. What do we already do in-house? What can we provide externally, perhaps even in a health-related context? A little task for you right now. Again, sorry, I'm aware of another task. I want you to have a look at this piece of research for me. A trial in 2020. And it's a trial that looked at strength training, vitamin D supplementation, and omega-3 supplementation on an elderly population, people over the age of 70. And it provided a strength training program kind of 3 times per week. And it did so over, I think, of a multi-year period. It's a very, very large study, multi-site study, and done over an extended period of time. The participants, before they came on, already engaged in some sort of moderate to high levels of physical activity. What do we think were the outcomes of this particular study? Does anybody want to hazard a guess? Maybe somebody pop it in the chat. So what this study found, and this might surprise you, well, there was no benefit whatsoever of this exercise program, of this dietary intervention on any of the health-related markers that they looked for in this particular study. They looked at things such as fracture risk. They looked at things such as blood pressure. They looked at things such as physical performance. They had over 2,000 adults. The exercise program did nothing. Why did the exercise program do absolutely nothing? The exercise program did absolutely nothing because of this. And what I've got here right here is a very basic principle or concept that might be, I'm aware of some of the people in the room might have knowledge of this, which is great for me right now. But for those people that don't, what this diagram represents is how exercise, a very simplistic model of how it works, particularly strength training and strength-related exercise. What we need to do with strength-related exercise for a process that's called mechanotransduction is elicit an adaptive response. And the way that we elicit that adaptive response is through a concept called mechanical loading. We put our bodies under strain. We lift some weights. Our bodies recognize that these weights are heavy. It places strain on our joints. It places strain on our bones. It places strain within the muscle tissue itself. And that creates a cascade of events. But in order to do so, that strain needs to be of sufficient magnitude and duration to elicit an adaptive response. It has to create a need for your body to adapt. Okay, so what we've got right here is, as an example, which you might see hopefully over these kind of things here, is that in order for us to get consistent adaptations in terms of strength and resistance training, is that we need to consistently go beyond our previous levels of performance, our previous levels of fitness. If we don't, then we don't adapt. That previous example, that previous study that I spoke about, the reason why it found potentially nothing was because the exercise stimulus wasn't enough to elicit an adaptive response. It was too simple. It was too easy. Regardless of the fact that the people were 70 years older, they were already engaging with physical activity. They needed to have done more. This approach, this model, and you can see this here, some sort of stimulus. The stimulus creates some sort of adaptive requirement. This is just fatigue. We get tired, we get fatigued, we get sore. We don't necessarily, we feel like our bodies and our muscles are a little bit tight, a little bit sore, and we over adapt over time. Yeah, and we improve and we get better. The evidence with a range of different performance-related contexts is kind of explicit that this kind of exists. And this is just an example of a study that kind of looked at a variety of different performance-related outcomes over a short intervention period, only 72 hours. This model kind of exists, kind of can be seen. Another thing I wanted to highlight very, very quickly. All right, I want you to have a look at this diagram for me. This diagram for me, again, it's an older population study, this. Looks at the effects of power training, so doing things with high velocity, as well as traditional strength training, just lifting kind of weights normally, on a range of different performance variables. You don't need to understand what those variables are. I don't need you to understand. What I'd like you to be able to do, though, is to be able to look at this and determine what is it that you see right now. So the bars in this graph represent individual participants in the study. What do you notice about those bars? You know, I'm not going to ask you to do catchphrase, say what you see. If anybody remembers that, they might have a little chuckle. If anybody doesn't, I'm very sorry for my silly joke. But what we've got right here, right now, is, I'm going to give you the answer. We've got some people that are adapting to an exercise program. It's power training and high intensity interval training. They've got some negative adaptation. They've gotten worse. So their previous level of whatever this particular variable is looking at got worse as a result of participating in that intervention. Yet we've also got people that took part that have had massive improvements as well. So what we see with exercise, and this is a universal concept, is inter-individual variability. How I respond to an exercise might be different to how you respond. It might be different to the person sitting next to you. And what is even crazier than this is that potentially there's intra-individual responses as well. So what might work for me right now might not necessarily work for me in 6 months' time, might not necessarily work for me in 2 years' time. This highlights the need for programming to be individualized to a degree, to kind of think of what is it that we now kind of need from an individual level to reflect someone's requirements. This concept of inter-individual response heterogeneity has existed for a long period of time. It's well known in sport-related context, and a whole host of what's highlighted on the screen right now, non-modifiable factors and modifiable factors, kind of underpins that. Things like your stress levels outside of work will impact your adaptability to exercise. Things like your hydration status, things like the food that you eat, your nutritional status, as well as a whole bunch of, I guess, non-modifiable factors as well, kind of how old you are, things like that. We have this kind of effect. What we need, if this individualization, which is one of the major underpinning principles behind exercise program, we need some degree of diagnostic examination. We need what we call a needs assessment, a needs analysis. It needs to be individualized to a degree. We need to understand what people need in order to get better. Does that sound like personalized medicine to anybody? Does that sound like stratified personalized care? These are things and words that are discussed in medical related contexts. So I want to provide to you as well, I'll give you another example of some sort of sample research. I want you to have a look at these studies. What we've got is a number of studies that have looked at resistance training interventions in older populations. And what you might potentially see on the screen right now, and I suspect if I just kind of highlight a couple of these, is two studies of very, very different length. One study was 3 weeks long, one study was 11 weeks long. One exercised people 3 times per week, one exercised people 4 times per week. One was 40–70% of a percentage 1RM, which is just an estimate of how hard somebody work, relation of how much they can lift. And one was exercised at a degree of intensity that was categorized as moderate effort. One was chair-based and supervised, one was machine-based. The research looks very much like this in older populations. Now, I'm not necessarily saying that's wrong. I think there is a place for machine-based exercise. I think there certainly is a place for exercise on a chair, an exercise that's utilizing body weight or light load implements. But I don't think that this should be the only approach that we take with respect to exercise in older populations. And we'll see in a couple of slides' time why that's potentially the case. One of the underpinning principles behind high performance training is a concept called transferability. There's a concept also called dynamic correspondence. They mean the same thing. And the thing that determines that is a concept called specificity. And that's the idea that if we want to create some sort of adaptation, the training needs to reflect that adaptation. So if we're working with older populations, and we want older populations to move a little bit better, to resist the ability to fall, to be able to walk a little bit quicker, to be able to get up off a chair a little bit easier, to be able to walk upstairs, to carry some bags, to undertake activities of daily living, well, how we program and develop an exercise program needs to have that in mind. Beyond some earlier adaptations associated with machine-based exercise, if we just do lots and lots and lots with it, we get good at machine-based exercise. All right, so I wanted to highlight very, very quickly Claire, who's a superstar PhD student I'm working with currently right now. And she's looking at exercise in an older population, specifically resistance training. And her PhD is looking very specifically at mechanical specificity. That concept I just mentioned a moment ago, that concept of things being reflective of what you're trying to actually achieve, rather than just being a variety of different things you kind of throw at a wall and hope it sticks. And what she's done through a variety of different meta-analyses and scoping exercises of the literature has found all sorts of issues, which might not come as a surprise to some of my colleagues in sport, with respect to things like science, scientific terminology, nomenclature. Professor Ed Winter, the late great Professor Ed Winter, spoke about this ad nauseum. My colleague Alan Ruddick does exactly the same. But also importantly as well, inconsistently reported exercise programs. And worryingly, exercise prescriptions that do not always reflect basic principles, things like specificity, things like overload, which we've spoken about already, things like individualization, basic concepts that are missing in the literature. Now, the final kind of piece of literature I wanted to highlight is something that I think might be of interest to some people with interest in related to this area. And what this particular study, you might be aware of it. It's again another really, really big study that looked at postmenopausal females who unfortunately live with osteopenia and osteoporosis. So living with low bone mass effectively, and some of the associated health implications because of that. What they did, in contrast to some of the previous literature, is they took these participants through a graduated progressive exercise program that started very, very small. They started with very, very minimal amounts of weight. They started very much, let's just learn the movement patterns and progress them over time in a small group exercise context, 8 to 10 people at once, to progressively lifting heavy barbell compound free weight exercises. To my colleagues in the room, I was aware of Dave Hember in the room right now, we'll look at this prescription and say, that looks kind of familiar. 5 sets of 5 repetitions, 80 to 85% of 1RM is exactly how you train an athlete if you want to get them stronger. What they also did as well was impact training via drop landing. So they got the ladies to do some jumping chin up kind of exercises and let go and land on the floor and work on their landing mechanics and their ability to absorb force. They did this for 8 months. They did it for 2 times per week. The sessions only took 30 minutes, not a massive use of someone's time. What were the findings? The findings were in comparison to a usual care kind of model of lower intensity kind of activity. Well, these kind of represent the effects of the higher intensity resistance training group. The variables at the top, broadly speaking, represent bone mineral density in the lower back and in the neck of the femur, in around the hip. Some of the negative variables there kind of represent some ultrasound kind of assessments, indicating that bone mineral density actually increased quite markedly as a result of lifting heavy weights and landing on the floor. The percentage improvements at the bottom represent strength-related variables that they took and performance-related variables that they took, such as things like basic assessments of strength, but also the ability to get up and move, also the ability to move around. I absolutely love this study. What this study demonstrates is that this kind of exercise, one of the things they looked at was feasibility, safety, and tolerability, and all those things. It was safe, there was no injuries, the participants loved it. Wow, that's music to my ears as a strength and conditioning practitioner. So where are the problems and where is the potential? Well, the 3 problems, the first, and I think that the potential in this university that I really, really want to stress and highlight today is through these organizations that are existing within this university right now. The first problem was participation and access and engagement. We're already doing fantastic work for the NCSEM, Move More, and I also believe there's incredible potential kind of lurking beneath the surface. So with the Health Transformation Project and the practice learning strand within that, what are the things that we can do as a higher education institute and as associated health-related organizations to understand the barriers, the social determinants, the things that are stopping people from engaging in order to intervene and to get people to do this kind of activity. If the research is telling us for ladies with low bone mass, low bone mineral density, suffering from osteopenia and osteoporosis, that this is safe, well, what are some of the things that we can start to do to address some of the barriers and hopefully allow some others to start to experience some of the fantastic benefits of this mode of activity? The second issue, I think, is around education, provision and standards and competencies. And again, I think there's incredible potential kind of sitting within this university right now. The AWRC, we have the Healthy and Active 100. We also have the CPD strand within the Academy of Sport and Physical Activity, within the College of Health, Wellbeing and Life Sciences, within the Portfolio and Recruitment strand of the Health Transformation Project. It's all about CPD, education, training, doing things differently. If we are going to get strength and conditioning practitioners working in a national health service, they need to have the knowledge, skills, competencies and experiences to kind of underpin that. We as a health-related higher education provider should be providing that. We have the expertise in-house already. We've got the networks and contacts throughout the university. We're already doing stuff in this space. Potentially with a little bit of joined up thinking collaboration, we can do even more. And we could be the leader in this particular area. And I think perhaps isn't of any surprise to anybody based on the last thing that I just spoke about. What I also see is a potential scope for novel and transdisciplinary research. Collaborative transdisciplinary research through the Health Research Institute, bringing together staff members from health and wellbeing, from academy and sport, and also people from the Advanced Wellbeing Research Centre. The research is perhaps not where it could be with respect to health-related context and strength and conditioning, but there's incredible potential there and there's incredible expertise that's already sitting within this institution. And then perhaps potentially the final thing really, which is perhaps the governor of all of this, is I think probably we need to look at data policy and public health guidelines. And I don't see any reason why we couldn't be leading that as well. Okay, that's my presentation done. I hope you've enjoyed it. I hope I've provoked a little bit of thought. I guess it's over to you for questions for me, really.